Hey folks, welcome back to the Brown Surgery Podcast. I'm your host, Dr. Kenneth Lynch. In this episode, we're going to continue our look into career decision making within the surgical subspecialties. Today, we're going to dive into becoming a hepatobiliary surgeon. We're going to take a look at what a day in the life looks like, some of the factors that go into choosing a HBB fellowship, address some of the misconceptions, and of course, touch on the often discussed work-life balance. Joining me to discuss this topic is our own HBB surgeon and assistant program director, Dr. Racheal Beard. So I'd like to welcome Dr. Racheal Beard to the podcast today.
No, thank you for the invite. Thank you for having me.
So Racheal, before we get started, can you just go through your educational pedigree for us?
So I went to undergrad at Boston University. I double majored in English and chemistry. I actually did a thesis on Shakespeare and then went straight to medical school at Jefferson Medical College, now called Sidney Kimmel, but it's Jefferson Medical College still to me in Philadelphia, and then went to residency, General Surgery Residency at Beth Deaconess in Boston. I spent 2 years between my second and third year of residency doing a combined clinical and research fellowship at the National Institutes of Health with the focus on surgical oncology and immunotherapy under Dr. Steve Rosenberg, who's really one of the fathers of immunotherapy. After I finished residency, I did a year of hepatobiliary fellowship at Pittsburgh before coming here.
Yeah, Racheal, when we do these segments on Career Focus podcast, I think it's nice for folks to hear about why you ultimately chose a career in surgery and what were some of the deciding factors that led you down the path of becoming a hepatobiliary surgeon.
So I actually had no intention of doing surgery in medical school. When I was in my first and second years of medical school, I thought I would likely do internal medicine, potentially with a focus in infectious disease. I actually spent a summer in Kenya when I was in college doing some medical volunteer work and got pretty sick with malaria, actually a few months after I came back in my third year of college. So I had an interest in infectious disease, having kind of had the firsthand experience. I scheduled surgery as my first rotation of clinical rotation of third year. My intention was just to get it out of the way because I heard the hours were going to be terrible, that the mornings were going to be early, and the people were going to be awful. So I wanted to just get it over and done with. So I did it first and actually really loved it. I really liked the fast pace. I liked the teamwork, loved being in the operating room. Most of all, I really loved the very immediate being able to see, the impact you have on somebody's life right away. I did internal medicine second and just kind of realized that I don't have the kind of personality or the attention span to round for, 6 hours at a time. It just wasn't something that engaged me quite as much. So didn't find anything else that I enjoyed as much as surgery and decided to go into that field.
Was there anything else that you were thinking about as you went on in your clerkship years, or was it just after that experience it was surgery from the get-go?
Yeah, it was pretty much surgery. I did OB-GYN and spent some time with one of the gynecology oncologists and enjoyed his big open abdominal operations, but then it was pretty much just surgery at that point.
So fast forwarding to you as an intern or a two, and your decision to go into the lab to do some clinical research, was that driven because you knew at that point you wanted to do HPB, or were you just trying to keep your options open, and what went into that decision?
So I didn't have the opportunity to do a ton of research when I was a medical student, so I really looked for a residency that was going to guarantee me some dedicated research time. And Beth Deaconess, I don't think still technically residencies are allowed to require research, but unless you came in with an MD, PhD, it was strongly encouraged, quote unquote. So I always planned to take 2 years out to do research. I actually almost in medical school applied to some of the combined vascular programs because I enjoyed vascular surgery as a medical student very much. And in retrospect, no offense to the vascular surgeons, but I'm very happy I decided not to do that. So I kind of thought about vascular and then thought about thoracic and, my interests were kind of all over, but realized that I did like working with cancer patients, kind of opted to do that as my research experience. A couple of residents in the program ahead of me had done it and had good experiences. Geographically, it also worked out because my now husband was going to Hopkins for his fellowship. So we were actually able to live together in Baltimore while he was at Hopkins and I was at the NCI. It's kind of funny. I know my husband said when, he was operating up in the chest and then down in the belly. As a resident, he was like, I want to be in the chest. And once he decided to do cardiothoracic, he was like, I hope I never go into the belly again. And for me, it was the opposite. I was like, I like being in the abdomen. I like cancer. So then I kind of really debated which way to go with that. I thought about colorectal, realized I didn't care for IBD. I didn't care for anorectal. So the only thing I really liked was the cancer surgeries. I thought about Surg-Onc, thought about transplant pretty seriously, actually, and then ultimately decided to do HPB and specifically to go the HPB fellowship route, which is one of a couple different ways you can specialize in HPB.
So in terms of residents who are thinking about their career choices and if HPB is a potential for them, do you recommend they absolutely do clinical research years?
Different decision making for everybody. I thought research time was really valuable. Not only the opportunity to actually do research, but just the kind of break in the middle of residency. It was 2 years to just have a little bit of a pause, reclaim your life, reclaim kind of control of your schedule, at least for kind of a 2-year spot. So I thought it was really rewarding and valuable for a number of reasons, and I'm happy that I did it. But I do think HPB is becoming increasingly competitive, and having research and having publications and having that dedicated time is certainly never a disadvantage.
So what would your recommendation be for lab years? Does it matter if residents do basic science or bench work, or should they focus on a specific area within HPB during these clinical research years?
I think do what you're interested in. I certainly don't think there's a requirement for it to be benchtop basic science research. I think the biggest thing is just showing that you're productive and can work hard, and if you can get experience in stats, all of that's positive.
So what does a normal work week look like for you now between your OR schedule, clinic, service requirements, obviously call? Is there ever a normal week for you?
So I usually operate 2, sometimes 3 days a week, and do clinic at least 1 day a week, also sometimes 2. So it varies a little bit. Usually on Mondays are when I do my bigger cases, Whipples, etc., sometimes liver resections. Some of my OR time is dedicated robot time. And then I do some 1 day a month in like the ambulatory surgery center doing some smaller cases. My practice right now is probably about 2/3 HPB and 1/3 general surgery. I personally enjoy doing general surgery, so I'm happy to spend a day doing gallbladders, hernias, sometimes even lipomas, and know that those patients are going to go home and like hopefully do well and not going to be in the hospital for a week with me kind of stressing about them and checking their labs and worrying about them. So I personally enjoy the mix of big and small cases and, plan to continue doing general surgery. There are certainly some HPB surgeons that only want HPB practices, but I like doing both.
That's a good follow-up. Like, what is the role of an HPB surgeon look like across different states or departments across the country? How many people do mixed general surgery with HPB? How many people do just straight HPB? Is that an option even?
So I think it's very variable depending on the type of institution you're practicing in. So for instance, at Beth Israel Deaconess, when I was there as a resident, the HPB surgeons, or actually were no HPB surgeons. The hepatobiliary was entirely done by the transplant surgeons, and then there were dedicated pancreas surgeons that only did pancreas. That split was also kind of how the setup was when I was at fellowship in Pittsburgh. So if you're at, a much bigger academic center, you're probably going to be subspecialized even more than like just HPB. A lot of people do end up specializing in liver or pancreas and not necessarily doing both. I would say a fair number still do general surgery, and that's where I think it a little bit depends on the route of HPB training that you choose, because unless you're at a really large major academic center, you're probably not going to be solely doing HPB. Most HPB surgeons, I would say, do something else as well. So that's one thing to think about. Do you want that something else to be breast, melanoma? If so, then surgical oncology training, going that fellowship pathway is probably a better option. There are people that do transplant surgery, but then also have, dedicated hepatobiliary practices. I would say a lot of surgeons that do HPB fellowship potentially are going to end up doing some general surgery as well.
Following up on that, with the different fellowship routes between HPB, transplant, and Surg-Onc, is that a decision tree folks need to make for fellowship if they want to do HPB as a career?
Definitely. I mean, those are kind of the different options, and there's plus and minuses to each kind of training route. There's, on any given year, 15 to 20, I would say, specific HPB fellowships that are accepting applicants. Some are 1 year. I think increasingly they're moving to 2 years, but some of those 2-year programs are only one fellow, so they accept every other year. So the exact number of open fellowship spots does vary depending on the year. There, are also transplant fellowships, which are all 2 years. If you do a transplant fellowship, you finish with a transplant certificate. What that certificate is in depends on the transplant program. So some of them are liver, kidney, pancreas. Some of them might be just liver, kidneys. A few number of them do like small bowel transplant as well, so that varies a bit. And then some of them, I would say definitely not most, but some have adequate HPB training to also offer an HPB certificate. So HPB certificates are granted by the Fellowship Council and the Education and Training Committee of the AHPBA, which I actually sit on, the AHPBA being kind of the major HPB body in this country. The HPB fellowships all award you an HPB certificate at the end, provided you meet all their requirements. There are a handful of transplant fellowships that offer that as well, and then a couple of the Surg-Onc fellowships have adequate HPB volume to also award you an HPB certificate. But that is something to definitely think about, because it's certainly not all Surg-Onc programs that are going to have enough HPB volume for you to really get adequate training. I think the same would be said of the transplant fellowships. Certainly some of them have a lot of HPV specific training, but not all.
So what would you say to residents who are considering a career in HPB? Are there any tips or specific advice you have for them?
I think just really think about what you want your case volume to look like and what you want your practice to look like. Yes, a Whipple is a very sexy and exciting operation. That said, dealing with leaks and complications and prolonged recoveries and all of that is not the fun part of it. So there are surgeons out there that do 4 Whipples a week, and that's their entire practice. I personally would never want that to be my practice. One of my favorite attendings in residency, who was also a very talented pancreas surgeon, but who had a pretty robust general surgery practice as well, like to say that every day doesn't need to be the Super Bowl. So I do think it is nice to have those days where you kind of go in and do some gallbladders and hernias and lipomas, and patients feel better, but they also go home and you're not having them in the hospital worrying about them.
So when looking for fellowships in HPB, what should residents really be looking out for in these programs? Obviously, robotics has rapidly become a standard of care for a lot of these procedures, and how does that weigh into their fellowship selection, balancing open versus minimally invasive approaches?
So I think it's important to, look at the numbers that the current fellows and past fellows are getting, and specifically look at the balance between liver and pancreas. Ideally, you want to have robust training in both, but I think there is some variability fellowship to fellowship. Some of them are very pancreas heavy, some of them are very liver heavy. So that's something to pay attention to, talk to the current fellows, and then, robotics is not going anywhere. I think it is, if anything, getting more and more integrated into HPB. And I think, in the next 10 to 20 years, it is going to be increasingly hard to market yourself and build a practice if you don't use the robot. And whether that's a good thing or a bad thing, is, I think, very debatable. But unfortunately, fortunately or whatever, I think it's just fact. So I think robotic training is important. There certainly are fellowships where you're not going to get it or not going to get a ton of it. There are surgeons that pick it up, on the other side of training and start using the robot as attendings. But I think being able to say that you're a surgeon that has a robotic skill set and can do these operations on the robot is never going to disadvantage you.
Are there any misconceptions about HPB that you want to address?
I think HPB, like a lot of other cancer-related specialties, but I would say especially true in HPB, is that it is very multidisciplinary and requires a lot of collaboration between GIs and oncologists, medical oncologists and radiation oncologists. Patients are complicated. Treatment options are not always straightforward. And, the data out there is constantly changing. So it's a lot of, somebody once described to me that, if you do an HPB fellowship and you're an HPB surgeon, you should have the technical skills of a transplant surgeon, but think like a surgical oncologist. So, they are technically challenging operations, but I think it's super important to have the oncology knowledge base. So, if you want the oncologist to give 6 cycles of chemo versus 8 cycles of chemo, and does the patient need neoadjuvant radiation, or can you skip that and go straight to surgery? Like, you have to be able to be fluent in that language. I think it's also just super important to get good at reading scans. Like, you are the only one that can assess resectability of a pancreas tumor. Like, nobody's going to tell you if it's resectable. That's a decision that you have to make. So really important to get adept at reading scans and knowing what you're looking at.
I think it's a great point you brought up about collaboration and the system around you, right? That's going to weigh into your job search, right? When you're done with fellowship and looking for a role that you think fits you, like, how important is the institutional support that you're going to get?
Oh, 100%. I mean, if your Whipple has a GDA stump blowout, you need to have a reliable interventional radiology department that can get that patient right down and take care of them. If you have HJ leak, you need a skilled advanced endoscopist that's going to be able to help you with that. So, that's why really, by and large, HPB surgery shouldn't be done in most community settings. Not that there aren't skilled surgeons in community settings, but it's about having that institutional and interdepartmental support. I think that is one of the more challenging things. You asked, kind of what does my average week look like? I would say a huge portion of my time on a day-to-day basis and a week-to-week basis is actually spent collaborating with primarily oncologists and also gastroenterologists. And, a very small portion of that is done in your traditional tumor board settings once a week. The vast majority of it is answering phone calls, secure chats, text messages, like, can you look at this scan? Is this resectable? And it's an enjoyable part of the job, but it's also a very time-consuming part of the job, especially because all of that is not necessarily things that you bill for or directly get paid for, but a lot of it is practice building referral bases, and just being a good partner to the people you're working with.
I think that's a great segue into the final question here. You're not only a great surgeon, but you're also a wife to a cardiothoracic surgeon, a mother of 2 children. So what's your take on balancing your home life schedule with your career schedule? Does work-life balance exist?
No, of course it doesn't. It's a fallacy. Lifestyle doesn't necessarily get better once you become an attending, by and large, exceptions to every rule. But it was striking to me, I saw my husband go from being a cardiac surgery fellow, working just insane hours and an absolutely brutal schedule, and then become an attending. And I thought that, his life was going to get so much better, and it got better as an attending, but it wasn't that much better. And cardiac surgery is still just a field with so many emergencies, and it's so unexpected, and, having to run in and open chests and all of that. So it was really kind of a heart-to-heart moment I had with myself, thinking if we do want kids and we do want a family, can't both have these totally insane, unpredictable lifestyles. So that was one of the reasons I decided to go into HPB. There are not a ton of cancer emergencies, and things like cut bile ducts, while they do happen, I wouldn't say that they're super, super common. So for the most part, my weeks, even though they are busy, the surgeries are mostly planned operations. There's the occasional take back of a Whipple, something like that, but thankfully that's not very frequent. So it does give me more control of my schedule, I would say, certainly, than my husband has. I'm definitely the one that's usually home with the kids first in the evening, getting them, oftentimes my son, to daycare in the mornings. Somebody kind of has to be the one that shoulders most of the household responsibility. And I do that, and I'm happy to do that. I think, my favorite job in the world is being my kid's mom. That said, the stretches that I had where I was home on maternity leave, I remember in my very naive pre-child days thinking that stay-at-home moms had these easy jobs, and that's just ridiculous, because I think being a stay-at-home mom is probably the hardest, most stressful job out there. And I enjoy my time at work. I enjoy my time at home. I often feel like I spend the entire week staying caught up at work and getting behind at home, and then I spend the weekends trying to get caught up at home, and then you start it over again on Monday. So I'd say there's very little, if any, like downtime, relaxed time. You do kind of always feel like you're playing catch up, but pay for more childcare than you think you need. We've been super lucky with our childcare providers, and we do have multiple. Having reliable people that can take care of your kids when you're not there is priceless.
Awesome. Well, our students, residents are making these career decisions every day. So again, I appreciate you joining us to talk about your decision into going into hepatobiliary surgery and your journey. So I think a lot of folks will benefit from it. So thank you.
Absolutely.
So thanks again to Dr. Racheal Beard for joining us today and speaking about her career decision-making into becoming a hepatobiliary surgeon. We have a lot of great episodes coming up as we continue our Chief podcast series. We will be speaking about necrotizing soft tissue infections and robotic surgery on the next few episodes. If there are specific topics and/or specialties you'd like me to dive into in this podcast, please email me and I'll put my email address in the description below. Have a great week, and I'm looking forward to having you back with us in the next episode of the Brown Surgery Podcast.